Good evening, everyone, and welcome to today's webinar on what's new in flu, current challenges and management option. For this webinar today, we have with us our guest speaker, and I would like to take a moment to introduce him. Today, we have with us Dr. Pramod Jog. Dr. Pramod Jog is a pediatrician and neonatologist from Pune and has an experience of 38 years in this field. Dr. Pramod Jog is a professor of pediatrics at Dr. D.Y. Patil Medical College, Pune, and also Dr. Pramod Jog was ex-president of Indian Academy of Pediatrics in 2016. In addition to that, Dr. Pramod Jog was ex-standing committee member of International Pediatric Association and ex-steering committee member of Gavi, CSO and SC, and Dr. Pramod Jog practices at Jog Children's Clinic in Aun and Pune. He completed his MBBS as well as MD Pediatrics from BJ Medical College, Pune. So with this introductory note, I would request Dr. Pramod Jog to start our webinar for today. Over to you, sir.
Thank you, Dr. Manohar. I will just start sharing the screen, and I'm sure I am audible and the screen is visible. Is it so? Fine? Okay. Thank you. So, actually, the topic for the day is what is new in flu. And in fact, my dear friends, remember that every year we get a different influenza vaccine. So that is something new that we already know. Now, this strain of influenza, which has been in circulation during the last maybe 1 or 2 months, is called H3N2. And in 2009, we witnessed the pandemic of H1N1. Okay. And this particular influenza virus, which is an RNA virus, I call it as a naughty virus because it changes its structure and it deceives so many people. You know, people feel that now after one influenza infection, probably we will get immunity against influenza for a long time. But it doesn't happen because it changes its structure. And then next year, again, it creates a problem and a lot of morbidity and mortality. So the WHO has to collect the data from different regions of the world and find out as to which were the strains which created problem in monsoon, which were the strains which created problem in the post-monsoon period, and those which created problem somewhere in the winter. So with all that data, WHO instructs the vaccine manufacturers to bring a vaccine based on the previous year's strains in circulation in the atmosphere. Okay, so it's a tough job for everyone to keep a track of all these strains, and that's why it's necessary that we know many things about this flu. And the first thing you must know is the nomenclature. And you can see my name in this particular slide has been Z/Pune/8/1958 PP. So it indicates various things about the virus as to the place from which it originated, then what was the year in which it was isolated, and so on and so forth. Okay. And just for your information, I was the 2016 strain of IAP president. Okay. Now, I came across a boy who was 3-year-old with fever, cold, cough, and progressive breathlessness for 3 days. And the child was tachypneic. The respiratory rate was on the higher side. The blood gases were showing acidosis. And the saturation of oxygen was only 85% in the room air. We were worried. We took an X-ray which showed ARDS. And we admitted this child to the intensive care unit. We ventilated the child and then also gave Oseltamivir, the antiviral agent against influenza, and also the supportive treatment. The counts were there, which you can see that the CRP is normal, okay? But the total count was on the lower side, and the throat swab was positive for H1N1. He was ventilated for 3 days, and then he was all right. Now, you would ask me as to what is so different about this child. The child came with, fever, cold and cough, and he became serious, and then you ventilated him, so on and so forth. But the point is whether we could have given Oseltamivir early when this particular previously healthy child presented with the respiratory symptoms and progressed over 3 days. whether the treating clinician would have prevented this progression, and whether every patient of cough, cold, and fever should be given Oseltamivir upfront in the flu season without the nasopharyngeal swab testing for flu. So that is something that we are going to discuss today, because there are many points which are creating confusion, and that is the confusion about the flu virus. Okay. So the first thing, whether the child comes to you with fever, cough, and cold, whether he has a bacterial infection or a viral infection. Now tell me as to how you differentiate. It's not difficult at all. So a child who presents with cold and cough actually most of the times has viral infection, because runny nose, cold, sneezing is something which is very, very, very close to viral infection. I always say that sneeze and wheeze, these two, if you find in a child, and mostly the change in the voice, then it's viral, and many times I am not worried. Viruses attack different parts of the respiratory system. So the same child will have cold and cough. The same child will have, infection which will create discharge from the eye. The same virus can involve other systems and produce rash, can produce diarrhea, so on and so forth. But bacterial infections are localized. The child will get follicular tonsillitis. The child will get tender cervical node, localized infection. But the same child won't get bacterial pneumonia. Okay. And if you give paracetamol, a child who has viral infection, fever comes down, child starts playing, and mother says he's the normal self now, he's fighting with the brother. But when a child gets bacterial infection, you give paracetamol, fever comes down, but the child still appears sick. He is lying down, not eating well, and mother says, Doctor साहब आपने दवाइयां तो दे दी, लेकिन कहीं कुछ प्रॉब्लम है, बच्चा ठीक नहीं लग रहा है. So ढीला सा पड़ा है, something like that. So in case if it is a bacterial infection, many times the child continues to be sick, doesn't eat well, doesn't play well, doesn't sleep well. And this is what you must remember when you want to differentiate the bacterial from viral infections. Now, if you find that it is a viral infection, you have to find out which is the virus. Is it rhinovirus? Is it adenovirus? Or whether it is influenza, or whether it is COVID, something like this. And then if it is influenza, whether it is H1N1 or H3N2, and whether I should start Oseltamivir upfront without waiting for the laboratory diagnosis, and whether I should give it in every patient, to play safe. So we need to see what are the various challenges related to influenza, the complications, and then what is the place of Oseltamivir, and what are the guideline recommendations for the use of this molecule. So recently, a small little girl aged around 5 to 6 years came to the OPD with a small little doll. And while I was examining this girl, the girl was speaking to the doll and telling her, viral hai, fikar mat karo, don't worry, it's viral. So even small children know that viral infections are usually not very serious, but this has been probably a story of the past. Now, when a child comes to me and when I find that this is viral, many times, I get scared, because we have seen so many children with influenza becoming serious, so many patients of COVID becoming serious, so many children with adenovirus, who are lingering on fever and cough for a long time, so on and so forth. And that's why we have to be careful. Though it's viral, you cannot take it lightly. Okay. And after this particular, COVID period, last year, somewhere in the months of June and July, we witnessed that hand, foot, mouth disease. That was one wave of a viral infection. Then we witnessed respiratory syncytial virus. Then we witnessed measles virus. Then we witnessed this H1N1. Then we witnessed adeno. And now we are witnessing H3N2. And what I have seen is that even older children are getting affected with these problems. So in the OPD, there have been children who have recurrent respiratory infections. There are children who have otitis media. There are children who have adenoidal hypertrophy. And many of them, they come to us for mouth breathing and snoring at night. I told you that influenza has been on rise, but this surge in influenza, the rise in the cases, has been unseasonal. Most of the parts of our country, we usually are familiar with influenza in the monsoon and the post-monsoon season. But here, To have influenza in the month of March and April is something unseasonal. And then, as I told you, the adenoviral outbreak has also been witnessed by all of us. So this adenovirus has really become a bad adenovirus. It's virus which is behaving differently. The presentations are varied. The child not only comes with the exudative tonsillitis, some of them are coming with, of course, pneumonias. Some of them have had effusions, though the common presentation of adenovirus is a pharyngoconjunctival fever. And these children, they are not settling in 5 days. They are taking 7 days, 8 days, to settle. To the tune that, at the end of 3 or 4 or 5 days, our colleagues are getting jittery. Ye kya ho raha hai? Like, I have been treating this child with antibiotics also for the last 2 or 3 days, but the fever is not going down. Viral infections by this time should have settled, but they are also not settling. So adenovirus is posing many challenges in the diagnosis also. And the diagnosis is difficult because adenovirus produces increase in the WBC count, it increases the CRP and so on and so forth. And that is why many parents, they want to know what is the diagnosis, what's going on. And these are the patients wherein you have to really think whether you need to do the nasopharyngeal swab. And there have been, dilemmas and confusions about the therapy with antivirals. There are problems whether we should continue antibiotics in a child when influenza has been diagnosed, or whether we should discontinue antibiotics which have been started earlier. We have also seen children who have probably a requirement of a metered dose inhaler and steroids, and these are the intranasal steroids. So some of them, they do need them. So let us say this child who is Viru, he's a child because he has viral infection. I have labeled him Viru, though this case is a real one from my OPD. He had fever for 3 days with cold and cough, and he was on metered dose inhaler since 4 months. He was well controlled with that. And with cold and cough, I gave him the symptomatic treatment. And he came back after 3 days. He was afebrile for a day and get fever again. In between, he is quite active. Now, the question is whether this particular child requires antibiotics. Remember, these are recurrent viral infections which are becoming more and more frequent. They are occurring at a shorter interval, and there is no reason for you to give any antibiotics. Okay, that is simply because the onset is with cold and cough, and the symptomatic treatment will take care of this particular problem in majority of the cases. These are called as back-to-back viral infections, and you are not to worry about it. Children, they simply go to the school, and within a day or two, other children infect them again, and this child becomes unwell and comes to you again. Okay, so these parents are bound to ask you, Dr. Jog, how is it that my child is getting so often illnesses, which you call as viral? Is that the immunity of my child is low? This is a common question which parents ask, isn't it? So please tell them that during the COVID times, these children have not been exposed to the viruses in the atmosphere, neither to influenza nor to adeno, nothing. And all these children who were sitting at home have not developed any immunity against some of these viruses. And that's why these viruses now are creating a problem. Children, if they would have had some immunity against influenza, probably the infections would not have occurred, but it doesn't happen. And that's why you have to counsel the parents. I told you that in adenovirus, sometimes the problem continues. In fact, some of my colleagues see that the fever, cough continues for almost 3 weeks. So what I do is I usually tell them, see, this appears to be more of adenovirus which is going on. And by the end of 3 weeks, the child will be fine. Now, if the child settles in 2 weeks, credit, of course, goes to me. And that's why you have to be very, very careful when you talk to the parents. And for that, and to understand a bit more about the respiratory viruses and influenza in particular, you have to know as to which organisms love which part of respiratory system. For example, the respiratory system, upper respiratory system, the nose and the areas around, they are attacked by the rhinovirus. So it's 100% viral. When it's tonsillopharyngitis, then it is in 70% cases, it is viral with rhinovirus, influenza, parainfluenza, RSV, adeno and entero and so on. Okay, even Epstein-Barr virus and so on. But In 30% cases, the problem is bacterial, where we get group A beta hemolytic streptococcus in 30% cases. Okay. Remember, any red throat is not bacterial infections. However, in bacterial infections, the throat appears fiery red, very red, and there is a cervical node which is tender. While in case of adenovirus, you do get redness of the throat, but it is not that fiery red, and the onset is not with the tender cervical node. Remember that. And otitis media and sinusitis, usually in most of the cases, almost 70% cases, are again bacterial. Okay. However, in rest of the cases, they are viral. Pneumonias, as you know, are again in majority of the cases viral, but in few cases they are bacterial. Remember that if you get pneumococcus and Hib from the throat swab, they are the colonizers and they are not the pathogens. Remember that. One point you must remember, that it is necessary to identify the enemies. How to identify these enemies? So if the onset is with cold and sneezing, it is rhinovirus. It's nothing but the common cold where upper airway is involved. There is either mild fever or no fever. Child is not exhausted, not weak at all, and children are playing well. This can occur with influenza and parainfluenza and RSV also. Along with high fever, if the child has headache, myalgia, muscle pain, extreme weakness, then it is majority of the times flu, and you are justified in starting Oseltamivir. Remember, these children many times are picked up by the parents because children have a lot of pain in the muscles. They are weak and they have fever with chills. So parents usually bring them, lifting them up. Okay. Adenovirus, as I told you, not only produces pharyngoconjunctival fever, but also produces non-respiratory manifestations. And my teacher used to ask me, Pramod, tell me, which is one respiratory virus which produces more non-respiratory problems, and that's adenovirus, which can produce diarrhea, mesenteric lymphadenitis, and hemorrhagic cystitis, and so on and so forth. And in a child who is younger than 1 year, you must remember bronchiolitis, which is caused by respiratory syncytial virus. And we are all now familiar with a child coming with fever and dry cough, with probably loss of the sense of taste and smell, and that is COVID-19. As regards the bacteria, I told you that if there is follicular tonsillitis in a febrile child with tender cervical node, always think of streptococcus. Fever, grunting, and tachypnea, think of pneumococcus. The mother will say that bachcha sota hai lekin raat ko karata hai, like that. Okay, so that is pneumonia. And then if the progression is very rapid, the child progresses from pneumonia to effusion to empyema with pneumatoceles in the chest, then that is staphylococcus. And in a child who is beyond 5 years, if he comes to you with predominant cough, it's mycoplasma, where signs are less, but the symptoms are more. Okay. So this particular child, 4-year-old with fever going on for 5 days, was not settling with oral medicines, was, admitted as the fever was not coming down. And on admission, he had tachypnea. He needed oxygen support. You can see that on the right side, the pneumonia is developing. And this child had mild derangement of liver functions, but the nasopharyngeal aspirate was positive for H3N2. And this was a child where you can see that the WBC count was low, 1620, and the platelet count was also low, 132,000. What I'm trying to tell you is that when a child comes to you to the OPD with minor symptoms like cold, cough, and mild fever and some throat irritation, you need not worry whether this is flu, whether this is COVID, whether this is adeno. It's going to settle on its own because the symptoms and the presentation is really mild. However, when a child gets admitted, when a child gets lower respiratory symptoms, and when a child fever does not come down, then you are fully justified in sending the nasopharyngeal swab for influenza and COVID and RSV and so on and so forth. And that will give you the diagnosis. Now here, in case if you get the swab positive for H3N2, then are you going to continue the antibiotics, or whether you are going to discontinue antibiotics provided you have started? Now it's a $1 million question, because on one side we say that when it is diagnosed as H3N2, we need not give antibiotics, which is, we have the diagnosis in front of us. However, I will explain this particular point little more in some of the subsequent cases. Now, this S3N2 also was found in another child, a 3-year-old child with cough and fever for 5 days, where fever was not settling. Again, you can see the X-rays of this particular child. And in a child where counts were normal, but the CRP was on the higher side. And you can see the right side of the chest in the X-rays also showing some infiltration. Again, turned out to be S3N2. And a child who was 1-year-old with fever, cough, cold, and status epilepticus-like presentation had nasopharyngeal aspirate showing S3N2, and the MRI showed non-specific changes of encephalitis, and the CSF was normal, and he was labeled as influenza encephalitis, a complication which is known in younger age group. Okay, and in this particular child, who was a 7-year-old daughter of IT sector parents, came to me for high fever for 3 days with throat irritation and exam. 2 days later, the parents were literally after me to do something. The throat was showing only mild congestion. I told him I'm not going to do anything except giving paracetamol. Okay. They said, sir, the flu and the adenovirus are around. Why don't you do something more than paracetamol? So remember that CBC and CRP, whether we need to do that. See, adenovirus, as I told you, produces increase in CBC and increase in CRP. So even if these values come high, they are of little help. Throat swab. Remember that in a child who has mild symptoms, as I told you, in this particular child, there was only throat irritation and mild congestion. There is no reason to, spend the money on throat swab, because the viral panels these days are not so cheap. And in case if the parents have economic problems, it's very difficult to proceed with these investigations. In case if the parents ask you about Oseltamivir, please remember, Oseltamivir is given as a presumptive treatment to some of these children who come to you with symptoms which are very, very, very suggestive of influenza. But it all depends on the severity of the symptoms. And that is why you have to remember that in a child who has mild symptoms, you can always wait for a while. However, in a child, now, for example, this boy, Tejas, 3-year-old, who comes to me for cough for a week and high fever for 3 days with crepitation. See, here now there is low respiratory involvement. The child already has been put on co-amoxiclav and has been admitted for persistent fever. And I really don't know what's going on. He has been put now on intravenous amoxiclav. The CRP is normal and the throat swab shows influenza A. And here in this child, Oseltamivir has been added simply because this particular child has proved influenza with low respiratory involvement. And here you are fully justified in discontinuing the antibiotics. However, as I told you earlier, influenza in 25% cases comes with co-infection with either Streptococcus pneumoniae or with Staphylococcus. And that's why you have to weigh the situation individually and then decide whether you need to continue the antibiotics or whether you would like to stop the antibiotics. However, if the younger brother of this particular child, this child has been positive now for influenza A, but the younger sib has come with high fever for a day, what will you do? Obviously, you have to give Oseltamivir to this child who has been in contact of this particular influenza proved child. Okay, one has to remember that the spreadability, the transmissibility of influenza to others is quite high. This is called as R0 or R0. Okay, that is the number. That means an infected child, to how many children will he spread this infection? So you have to remember that influenza, measles, COVID, all these are transmitted to a great extent from one child to the other. Okay, and that's why it is necessary that we know the details and the KYC, know your customer form of this influenza. Okay, and as I told you, it's a naughty virus, which is RNA virus, and it has 3 types, A, B, and C. I already told you that there are some proteins on the outer side of this particular virus, and I will show you a picture. This particular virus has created so many problems till now. It has produced 4 major global pandemics. Most of you are aware that in 1918 and 19, there was a pandemic of Spanish flu, which was H1N1. 1957, there was a pandemic of H2N2. 1968, there was a pandemic of H3N2. And in 2009, we had pandemic of H1N1. And in that Spanish flu, 1918-19, there were 500 people who were affected and 50 million people died. So it has to be, taken quite seriously. And the virus is linked to the high fever and the cough cases going on in the atmosphere. And the cold wave and the fog and the rising pollution, they trigger the surge in the seasonal flu cases. And whenever children get admitted to the hospitals with respiratory symptoms and maybe with low respiratory involvement, it is necessary that you screen these children for flu as well as for COVID so that we know what's going on. Okay. And my dear friends, flu has not remained a seasonal disease, but it has become a perennial, year-round condition. Okay. So there is a surge in the cases of high-grade recurring fever in children. And whenever a child comes to you with runny nose, fever and cough, along with body ache and along with weakness and headache, then you have to be very, very clear that it is most likely to be influenza and you have to start with Oseltamivir. ICMR in the initial 3 months of this year gave us the statistics which told us that H3N2 is the major virus which is circulating in the atmosphere. And we have to be very, very careful when we move in the society and decide whether we really did move out or whether we can stay at home. And there have been various studies like this one from Tamil Nadu, which tells us that, the influenza positivity starts with the onset of monsoon and peaks during the post-monsoon period. The influenza-related deaths are also increasing alarmingly in India. And to know a bit more about this virus, remember it is one of the most common infectious diseases caused by influenza virus and highly contagious, airborne, producing seasonal epidemics, and children come with acute febrile illness and it can cause mild to severe illness. And remember that serious children might require hospitalization. Okay. As I was trying to tell you, influenza A, B, and C are the 3 types, of which influenza A is the one which produces major pandemics in the world. And every year, this is the strain which shows a change. So if you look at the influenza vaccine over the last 5 years, you will find that the strains in the vaccine have changed only as regards influenza A. So that H1N1 keeps changing. Okay. And the virus grows in the birds as well as grows in the human beings. And the viruses are combined together in the pig. So the pig acts as a mixing vessel wherein the H and N related virus from the birds, they mix up with the H and N related virus from the human beings, and together there is a new virus which is produced. And this is possible only for influenza A because the virus exists in birds as well as the human beings and then in the pigs. So this is the reason for a pandemic. So this H1N1 suddenly will become H2N2 or may become H3N2. This is a major change. Okay. But sometimes it remains H1N1 with minor changes which are occurring in the amino acid sequence of the proteins on the outer side of this virus. Okay. So you have to be very, very clear that the pandemics are always produced by the H and N influenza A viruses. This is important. And to explain what is a shift and what is a drift, remember, if, for example, my name Pramod changes from Pramod to Vinod, then it's a minor change. Okay. And this is called as a drift. But if suddenly my name Pramod changes to Bhaskar, okay, then it's a major change. And that is called as a shift, which is responsible for pandemics. Influenza B infects only human beings and produces local epidemics. As it doesn't exist in animals, there is no question of any pandemic. And influenza C virus infects human beings and the swine, the type C infection generally causes a mild respiratory illness, and they are not thought to be the cause of epidemics. However, right now the circulating types are H1N1 and H3N2. And as I told you, the transmission of the flu virus occurs up to about 6 feet from the person who is coughing in the form of droplets. These droplets will sit on the mouth and the nose who are nearby and then inhaled into the lungs. And that's why we should stay away from these affected people, and even the affected person should stay at home. Most important thing is that the transmission begins one day before the symptoms, and in adults it continues for a week, but in children it continues beyond 7 days, up to 10 days or even 14 days. Remember, my dear friends, that all the viruses that I told you till now, the adeno, the RSV, the human metapneumovirus, the influenza, parainfluenza, COVID, it is humanly impossible to differentiate simply from cough, cold, and fever. All these viruses will produce similar symptoms, and I always say that even Rajnikant cannot differentiate these viruses. Now, is there a real need to differentiate the two? The two, that is flu as well as COVID-19, if you're having some clue at the back of mind, which I call as educated guess, it will be of great help. Because fever, muscle pain, and then the weakness and the cough and sore throat, they're all common to influenza or influenza-like illnesses, okay, and COVID. However, COVID virus, as you know, rapidly spreads to the lower respiratory tract, and the two viruses which can attack the lower respiratory tract are influenza and COVID, and breathlessness can set in quite fast. You know that the loss of smell and loss of taste are known in case of COVID-19, and of course, a headache is a prominent feature of influenza. Diarrhea, for your information, may be present in a child who has COVID-19, okay? And that is why it is necessary to categorize the influenza-like illness cases. So, if the child has mild infection, it's category A. If the child has increase in the respiratory rate, it is B. And then if it is distress, and if there are some other dangerous signs, then it is category C. So, if the child has fast breathing or trouble in breathing, if there is cyanosis, if the child is not drinking enough fluids, if the child is not waking up, not interacting, and is so irritable that does not want to be held, and the fever has disappeared but again has returned with fever and worse cough, then you have to remember that these are warning signs and one has to be very, very careful. And there are some important complications of flu in the form of acute respiratory infection, which is either manifesting as pneumonia or ARDS, and acute otitis media, absenteeism from the school affecting the scholastic performance, and also absenteeism from the work for parents affecting the amdani, and that is the income, and then the antibiotic abuse. All these complications I have enlisted with the alphabet A so that you can understand that these are the reasons for which you must either prevent influenza or give influenza vaccine so as to avoid these complications, okay? So to know a bit about the complications, remember, otitis media occurs in almost 10 to 50% of children, and pneumonia is either of primary viral type, which is common in children who have some underlying risk factor and who are under the age of 2 years, while it is associated in 25% patients with either infection with Streptococcus pneumoniae or Staphylococcus aureus. Remember that the exacerbation of chronic pulmonary conditions like asthma, particularly beyond 2 years of the hospitalized patients, occurs, and respiratory failure in 5%. And there can be acute laryngotracheobronchitis. It can also complicate as a toxic shock syndrome or myocarditis and pericarditis, and some neurological problems like the simple febrile convulsion, the influenza-associated encephalopathy due to the cytokine dysregulation, acute necrotizing encephalitis, Guillain-Barré syndrome, and aseptic meningitis. I told you that myositis is one of the features more with influenza B, and in boys between 6 to 9 years of age, where there is involvement of gastrocnemius and soleus, and there is severe bilateral calf muscle pain and inability to walk. And in case if you give aspirin to a child with influenza, the child may land up into what is called as Rye syndrome. Now, coming to the management of influenza, remember that the bed rest and increase in the fluid consumption and the cough suppressants and antipyretic analgesics like paracetamol and non-steroidal anti-inflammatory drugs for fever and myalgia, they are common to all. Okay. And most of the patients with influenza will recover in 3 days, but the weakness may persist for weeks. And some of the cases may require hospitalization and intravenous fluid therapy. But the mainstay of therapy is Oseltamivir, which is a neuraminidase inhibitor. Remember that outer wall of influenza has two important proteins. One of them is hemagglutinin and other is neuraminidase. Now, hemagglutinin helps the virus to attach to the host cell. The virus has to attach because these viruses, all viruses are parasites. They cannot exist in the world unless they have some host. And neuraminidase is the one which is required for releasing the virions from the infected cell of the host. So, after neuraminidase is blocked, the virions cannot be released outside to the other cell. So you can see this particular picture wherein the virion on the upper part of this picture, and you can see hemagglutinin outside and neuraminidase. And this is a case where influenza is trying to pass on the virions to the other respiratory epithelial cell. But when you give Oseltamivir, the neuraminidase inhibitor, you can see the big red cross wherein this particular neuraminidase has inhibited and no virion release, leading to halted virus replication. This Oseltamivir is a potent and a selective inhibitor of the neuraminidase enzyme of influenza viruses, both A and B, and it's a prodrug. It is converted to the active form Oseltamivir carboxylate in the liver, and it inhibits influenza virus replication and further pathogenesis. It prevents further spread of infection also, and it's effective against all strains of influenza A and B. This was the first oral neuraminidase inhibitor, and Oseltamivir is approved in more than 100 countries. This is an important slide, most important, I would say, related to the dosages and the recommendations of Oseltamivir. Remember, an adult requires, as a part of therapy, 75 milligram capsule in the morning, 75 milligram capsule in the evening. 2 capsules of 75 mg to be given in a day. A child who is less than 15 kg, the dose is 60 milligrams per day. And when you have a 30 milligram capsule, you can give 1 capsule in the morning, 1 in the evening. And if a child is between 23 to 40 kg, he requires 120 milligrams, that is 4 capsules of 30 milligrams. So you can safely give 2 in the morning, 2 in the evening. Okay. So the recently launched capsule of Oseltamivir, which is 30 milligram capsule, is of great help because it can always adjust to the dosages of the child. Remember that the real therapeutic dose of Oseltamivir is 3 milligrams per kg total dose, which is given into twice daily doses. Now remember that for chemoprophylaxis, now in the house many times the child is unwell, and along with that the grandfather who is an asthmatic, the father who is a diabetic, and mother a pregnant one. These are all high risk conditions wherein you have to give chemoprophylaxis provided the child in the house has influenza, which is proved. Okay. And this is only to reiterate the fact that Oseltamivir 30 milligram capsule for a child who is 15 kg or less, for therapeutic purposes, you have to give it for 5 days in the dose of 30 milligrams twice daily. And for prophylaxis in the high risk contacts, you have to give it for 10 days, but the dose here is only once daily. So remember, for the dosage convenience, avoiding the wastage and economicity, you can always use the 30 milligram capsule. There have been quite a few clinical trials which tell us the benefits of the empiric and the early use of Oseltamivir, wherein it has been proved beyond doubt that the treatment of influenza with Oseltamivir reduces the lower respiratory tract complications, the antibiotic use, and hospitalization. I told you that these are the major complications, and also the occurrence and the severity of pneumonia. Remember, these advantages are not only restricted to the children, but also to the adults. And WHO recommends early empiric therapy. And as soon as possible, the laboratory confirmation of influenza virus is not necessary for initiation of therapy. Otherwise, you will just keep waiting for the report. Don't do that. Negative lab tests for H1N1 does not exclude the diagnosis in all patients. Okay. And if there are higher risk individuals exposed to a patient with influenza, consider the presumptive treatment with Oseltamivir. Remember that influenza in this particular season has been unusual because the season has been different and H3N2 is behaving differently. Remember, as compared to H1N1, H3N2 is producing severe forms of the disease, and there is also co-circulation of influenza B. So proper diagnosis and early treatment can prevent the flu complications. And the empiric use of Oseltamivir reduces lower respiratory complications, hospitalization, and antibiotic use. My dear friends, remember that leading bodies like WHO, American Thoracic Society, and the Ministry of Health and Family Welfare have recommended the empiric use of Oseltamivir. And a few words about flu vaccine. Remember that a short form in the form of Nescafe, NESCAFE, will probably make certain things clearer. So, whether there is a real need of the vaccine, the answer is obviously yes, because we have seen so many problems and complications with influenza. What is the efficacy of the vaccine? The viruses which are in circulation in the atmosphere, like H1N1, H3N2, and type B, Victoria, and Yamagata lineages, if all those are present in the atmosphere and also in the vaccine, then the match, that is the Kundali, is perfect. And that's why the efficacy is very good. Okay. But if there are different viruses circulating and different viruses in the vaccine, Kundali doesn't match and the efficacy may be on the lower side. Okay. And that's why it is very important that the most recent strain is taken up into the vaccine. Is the vaccine safe? Yes. Is it cost effective? Yes. Is it affordable? Yes. Is it feasible for the schedule? Yes, because we give 2 doses, one at 6 months and one at 7 months. And what is the epidemiological relevance? That already I told you that epidemiologically, in most of the parts of the country, the disease is in the months of monsoon. And that's why April and May are the months where we give the vaccine. And at 6 months completion, 1 dose. And at 7 months completion, the 2nd dose. And all those children who have completed 6 months and all those people who are in the house, who are in the high risk category, like the people who are above 65, the pregnant women, the diabetics, nephrotics, asthmatics, so many, with immunocompromised status, you have to give influenza vaccine. What I do is, in my clinic, I give this vaccine to all the staff members, the ward boys and the ayahs and others on their happy birthday every year. Because you all know that this vaccine is required once in a year. So I, in addition to telling them happy birthday to you, I also give them the vaccine and I tell them happy birthday to flu. Okay. So you have to remember this and maybe you can start this practice at your end. So my dear friends, this virus, as per one of the English movies, the name was Fast and Furious, is having onset which is abrupt, transmission which is high, progression which is rapid, ARDS which sets in fast, and children die very fast. And Oseltamivir, if given, acts quickly and then prevents the further progression. The most important thing is that use of Oseltamivir will reduce the duration of the illness by 48 hours. Even if you start Oseltamivir little later after 4 or 5 days, it reduces the viral replication, and that is why the disease complications are less, the hospitalization is less, and the mortality is also less. We all are aware of other preventive measures like the sanitization, mask, and following the social distance. And also the cough etiquettes, like coughing in the elbow, like this Dracula cough. Because if you cough in the palms, these palms may come in contact with the things around and the virus may spread. Okay. So this is a cough etiquette. And you have to follow 5 rules in relation to hand. 1, use your hands sparingly, but use them only after washing. So hand wash, avoiding handshake, using a handkerchief, keeping the other people at a hand's distance, and Also avoiding the hand touching of the parts on the face, like the nose and the mouth and the eye. This I call as Hasta-pancha-s. So with that, I am telling you to start saying namaste to the people around. Even the Westerners have taken up namaste from us only. So avoid the shake hand and start saying namaste, because flu ends with you. And that is why when you take care, when you start Oseltamivir early, and when you propagate and yourself take the vaccine, then flu can always be kept under control, and the complications and the hospitalization can be prevented. So with that, I have completed my presentation. I will stop sharing my screen, and there are certain questions from the delegates, and some of our colleague wants the guidance about the differential diagnosis of the bacterial and the viral infections. And I told you earlier that the bacterial infections are localized. If you get a child with bacillus dysentery, for example, he will have blood and mucus, but this child won't have cough and cold. Viral infections are generalized. In the same child, the child will have cough, cold, he may have viral pneumonia. And in the different systems, it will have presentations like, as I told you, cough, cold, and fever, some discharge from the eye, the rash, diarrhea. So you have to be very clear. So as soon as you come to know that this child has different systems involved, it is viral, and antibiotics on majority of the occasions are not required. Now, one of our colleagues also wants to know whether H3N2 infection can occur in vaccinated patients and what are the chances of complications. Remember, if a child is vaccinated, the vaccine contains H3N2, okay, and it is very unlikely that the child will get infected with H3N2, because the protection is good to the tune of 60 to 70%, okay, and the complications are also less. Now, one of our other colleagues wants to know whether Fluvir, that is Oseltamivir, is needed to be prescribed to vaccinated patients. Remember that the action of Oseltamivir usually is over in a week's time. What is the action of Oseltamivir? It's a neuraminidase inhibitor. Viral replication stop, the action of the medicine is over, and the medicine says, okay, I'm going back to my home. Okay, so no use. However, in case if outside there is a lot of flu, and in case if you want to give the flu vaccine, then you can always give flu vaccine to a person who has received Oseltamivir also. He has come out of the disease. You have stopped the replication, but it is not that the person is now immune to this particular virus, okay, and that's why it is better to immunize this particular person, so that at least for the next 1 year this person will be a bit protected against influenza, okay. And there have been different strains which have been included in the vaccine of 2023. And the basic strains remain H1N1, H3N2, and the two lineages of influenza B, that is Victoria and Yamagata. Whatever is the vaccine available in the market, please give it to the children, because the strains do not show much of variation. A minor change in the strain will be there, but the major part of the vaccine of the last year will remain in this year also. And that's why you have all the chance that the child gets good amount of protection against the vaccine. However, the immunity of the person wanes. It goes down after 6, 8, and 12 months slowly. And that is why every year, even if the strain remains the same, you have to take the vaccine, because the immunity wanes. Okay. So these are some of the important points, and I'm glad that our colleagues have asked these questions. So Mr. Manohar, in case if you have any other question, please feel free to ask.
No, sir, these are the questions which I shared with you. And at the end of this webinar, I would like to thank on behalf of Petro Healthcare to you as well as all the attendees for patiently listening, as well as giving your time to attend this webinar. And I hope all the attendees must be benefited with your clinical experience sharing and making this topic very simpler to all the attendees, sir. Thank you very much, sir, on behalf of Petro Healthcare, and thank you to all the attendees for attending this webinar on what's new in flu, that is current challenges and management. Thank you, sir.
Thank you very much.